Welcome to Echocardiography lecture series. This lecture will be about the mitral valve. It's part 1. I will speak about the mitral valve anatomy and mitral stenosis. So we'll start with the mitral valve anatomy. It is important to understand that we are talking here about the mitral apparatus, and mitral apparatus really consists of not only the mitral valve, but also the mitral papillary muscle, the chordae tendineae, the mitral annulus, the leaflets. LA wall is part of mitral apparatus, as well as the LV wall. And the reason also for the LA wall and LV wall, and because sometimes pathology in the LV or pathology in the LA can cause mitral valve disease. So now we'll proceed to the mitral cords. We have three types of cords. We have the primary cords that attaches to the leaflet edges, here and here. Okay, and then we have the secondary cords that attach to the body of the leaflet. And also we have tertiary cord. Tertiary cord is usually found only in the posterior mitral leaflet, and it is attached at the base of the leaflet as well as the annulus. So mitral valve has two leaflets. One large anterior leaflet and a smaller one, crescent-shaped leaflet, which is the posterior leaflet. And the posterior leaflet has three scallops that are separated from each other by indentation. So we have P1, which stands for the posterior one, and we start counting from the lateral. So P1, P2, and P3 scallop. And just let me erase it. So each scallop, posterior scallop, co-opt with anterior segment. We call it segment because it doesn't have indentation. So we have the A1, A2 segment, which co-opt with a P2 scallop, and A3 segments. Again, counting from lateral to medial. And then we have two commissures, the medial commissure and the lateral commissure. So the commissures, they separate the mitral leaflet at the edges. Now this view, we call it the surgeon's view. It's the same view that the surgeon sees when he opens the left atrium. So the surgeon view is from the left atrial perspective. This is the left atrial appendage. Also, it will be indicating the lateral side of the mitral valve. The aorta will be oriented at 12 o'clock, and this part here on the right will be the medial. However, in 2D echocardiography and in transthoracic echocardiography, if we take a 2D in short axis, we'll have this view. This view will look at the mitral valve from the ventricular aspect. So the lateral side is here, and the medial side here is on the left. It's not very clear. Let me just fix my pen. This is the lateral side, so we start counting from here, like P1, P2, and P3. And we have also the A1, A2 and A3, and this is the medial commissure here, and the lateral commissure is here. So again, in 2D echocardiography, we view the mitral valve from the ventricular aspect, and the RV is here. So again, this is medial. We have two major papillary muscles. We have the anterolateral here and the posteromedial. Sometimes we have an accessory papillary muscle. So each papillary muscle, whether being anterolateral or posteromedial, they have multiple heads, and they provide cords to the corresponding half of both leaflets. So the anterolateral will give both the anterior leaflet, the lateral side of the anterior leaflet, it will give it cords, and also the lateral part of the posterior leaflet. Similarly, the medial also will give cords and attachment to the anterior mitral leaflet, the medial part, as well as the posterior mitral leaflet, the medial part. However, also, it is nice to note that the anterolateral papillary muscle will receive usually dual blood supply. Yes, let me delete it. Dual blood supply from usually the left anterior descending coronary artery and the diagonal or the marginal branch of the left circumflex artery, while the posterior medial, this one here, usually it has a single blood supply that comes from the PDA artery or the posterior descending artery. So it is more susceptible for ischemic injury than the anterior leaflet. So now we'll speak about mitral stenosis. And mitral stenosis, to make it easier, it is divided into acquired mitral stenosis and congenital mitral stenosis. So the acquired, for example, we have the rheumatic, which is the most common. We have degenerative or age-related, and also inflammatory. In congenital, there is a parachute mitral valve, there is supravalvular stenosis, there is also double orifice mitral valve that we will speak on in details in the coming slides. So speaking of rheumatic mitral stenosis, still rheumatic fever is the most common cause of mitral stenosis worldwide. Upon morphological examination of the stenotic mitral valve, we can then determine the etiology. So in rheumatic mitral stenosis, the hallmark is commissural fusion, as we can see here where the arrow is pointing. So there is a fusion of at the commissural level. So that we can see clearly in the parasternal short axis view, while in degenerative mitral stenosis, the main feature will be mitral annular calcification that we will see in the subsequent slides. Also, we can see in degenerative mitral stenosis some leaflet thickening and calcification, but there is no commissural fusion. However, if you look here again, you can see there is fusion at the commissure. So if we play here this video, we see that there is thickening of the mitral valve. You can see the leaflets are thickened. Here, there is commissural fusion. Let me play it again. Also, if you note at the mitral uh, leaflet tips on the left side here, you will see that there is like hockey stick appearance. So the anterior mitral leaflet will be something like this. It will be attached at the tip, and this is because of the commissural fusion. We will have this doming of the mitral valve and the hockey stick appearance, as well as other feature like restriction of the posterior mitral leaflet. If you look at the cord also, you will see that they are thickened and calcified. This is a still image that will show the hockey stick appearance of the mitral leaflet that is due to the commissural fusion. M-mode was historically the only tool to evaluate rheumatic mitral disease, and the hallmark of rheumatic mitral disease on the M-mode is increased echogenicity of the leaflet and thickening. So this is the leaflet here. This is the anterior mitral leaflet. You will see it thickened and echogenic. And this is the posterior mitral leaflet here. You will see it also thickened. Another thing that we noticed in M mode, you will see that there is a decrease in the EF slope. So this slope during diastole, it will be decreased. Normally, you will have an E wave or an E motion upward, early motion, then the valve will come down to a semi-closed position, then you will have an A motion, and then the C where will be the closure of the valve. However, in mitral stenosis, no, you will have the early upward motion, which is the E, and then it will continue with slow slope, downward slope. Another thing we can also note that this posterior mitral leaflet during diastole, here you will see it moving anteriorly. So it moves upward. So it follows the anterior mitral leaflet. And the reason, because there is commissural fusion, it is tethered to the anterior mitral leaflet. So this is why it moves upward with the anterior mitral leaflet. This is a 3D presentation of the mitral valve, and in rheumatic mitral stenosis, the best way to evaluate for mitral valve is from the LV perspective. So this arrow represents the eyes where we are looking at the mitral valve from the LV perspective upward. So we can see the classical fish mouth appearance of the mitral valve here. This is the upper one is the anterior mitral leaflet, the lower one is the posterior mitral leaflet. Also there is commissural fusion here as well as commissural fusion also here. So because we're looking from the LV, the lateral side is here and the medial side is here, and always the aortic valve is at 12 o'clock. Now we'll move to degenerative mitral stenosis. So in degenerative mitral stenosis, it is characterized by mitral annular calcification, again without commissural fusion, and the leaflet may be thickened and calcified with restricted motion that will cause mitral stenosis. So if you look here, you will find area of calcification. This is the mitral annulus. We can see it here at the base of the posterior mitral leaflet. So mitral annular calcification or MAC is graded based on the extent of the calcification along the posterior aspect of the mitral annulus. So this is the posterior aspect of the mitral annulus from here to here. And then if the mitral annular calcification is occupying or affecting less than 1/3 of the posterior annular area, then it is mild. Moderate, 1/3 to 2/3. Anything more than 2/3, then it will be severe. In this example here, we will have the moderate, and in the other example on the right side here, it will be severe because it's more than 2/3 of the posterior mitral annulus. So this is a video of severe mitral annular calcification. As you note also that the annulus is usually, or the calcification happens at the posterior aspect of the mitral annulus. And here it is again severe, involving more than 2/3 of the mitral annulus. However, if you look at the mitral leaflet here, you will note that the mitral leaflet, both leaflets are moving freely, so we don't expect much of stenosis in that case. However, sometimes because of degeneration, the leaflets will be thickened and will have restricted motion, but without commissural fusion. So this is a video of the severe mitral annular calcification, and sometimes we can note a mobile element. If you look carefully here, you will note a mobile element or mobile component that will cause increased risk of embolization and maybe stroke, etc. Rarely we will see also caseous MAC or mitral annular calcification, where there will be a central liquefaction or liquefaction necrosis that appears as an echolucent core within the calcium itself. Also, that it means that there is again risk of embolization with this liquefaction. And this is a still image where we can see echolucent space within the mitral annular calcification that is consistent with caseous necrosis of the MAC. If you look here, it might not be very clear. You can see restricted motion also, and significant calcification. Here we can expect to have mitral stenosis or degenerative mitral stenosis. Autoimmune disease, classically systemic lupus erythematosus, SLE, will cause or might cause formation of sterile valvular vegetation. This is here the image or the video as transesophageal echocardiography, and here we can see this is the anterior mitral leaflet, and there is a mass on the tip of this mitral leaflet. It looks like a vegetation. However, this is an inflammatory changes, and it is a sterile valvular vegetation. It's composed mainly of immune complexes and platelet, and also it's a small thrombi. It was first described by Liebman and Sachs and is known as Liebman-Sachs endocarditis or verrucous endocarditis. This lesion can heal with fibrosis and calcification, and rarely it may cause valvular dysfunction, maybe regurgitation or stenosis. The echocardiographic appearance, if you look carefully at it, it will be like a rounded mass at the free edge of the mitral leaflet. So at the tip of the mitral leaflet, as you can see, and in short axis it will be appear as diffused thickening at the mitral leaflet tips. This is a still image, and if you see here, this is a transesophageal on the left side, where you can see the rounded mass that is at the leaflet tip here. And if you look in short axis, you will see the tip is thickened. See, the whole tip is thickened, diffuse thickening of the mitral leaflet tip. Again, there is no much commissural fusion. This is the commissure here is open, and the commissure here is also open. So now proceeding to congenital mitral stenosis, and we'll proceed to the parachute mitral valve. So parachute mitral valve is when there is a single papillary muscle, or the two papillary muscles are very close to each other. This will limit the mobility of the otherwise normal leaflets and produce an obstruction. So the hallmark of parachute mitral valve diagnosis is the demonstration of a single papillary muscle that we will see in the coming videos. But here you can see that there is a restriction of the mitral opening, and as if both they are directed toward one position, which is the papillary muscle, the single pap muscle here. It is commonly associated with other congenital heart disease like a cleft mitral valve or ostium primum ASD, or as part of Shawn complex. So this is an apical view of parachute mitral valve, and as you can see, the anterior mitral valve is a little bit tethered and restricted. This is because it's attached to the single papillary muscle here. So this is the anterior mitral leaflet, and it does not open freely. And here we can see a short axis view of the mitral valve. As you can see, there is a single pap muscle that can be demonstrated here, and here the pap muscle is the anterolateral papillary muscle here. We don't see any pap muscle in the posteromedial position. Another congenital mitral disease is the double orifice mitral valve disease. Here, if you look carefully, you can see that there is two orifices. We can see it clearly in the still image. One is here, the other one is here. It's a rare congenital anomaly of the mitral valve that is also characterized by two orifices that may cause obstruction. Since 2014, mitral stenosis severity classification changed, and it's classified now based on area alone. So it's not based on gradient or anything else. Normal mitral valve area would be from 4 to 6 square centimeter, and then we have the progressive mitral stenosis, which is any area less than that but is more than 1.5 square centimeter. And then severe mitral stenosis is when the area is equal to 1.5 or less square centimeter. And the reason that the new classification is mainly dependent on the area, because the gradient, for example, is dynamic. It changes with the heart rate. So still can have the patient have severe mitral stenosis and can be asymptomatic if the heart rate is well controlled, or maybe even in progressive mitral stenosis, patient can be symptomatic due to tachycardia. We know that in mitral stenosis, most of the filling occur during the diastole. And we will have a slow filling because of the mitral stenosis. So if the diastole is short in tachycardia, there is no enough time for the emptying of the left atrial volume. That will cause increase in left atrial volume, and increase in left atrial pressure will cause also the increase of the gradient between the LA and the LV. So mainly we go by the mitral valve area. So again, the mitral valve or the apparatus is more like a funnel shaped with the smallest orifice usually at the leaflet tips. Therefore, planimetry must be performed at the leaflet tips. In 2D planimetry, the mitral valve will be taken in short axis and should be obtained with a careful, slow sweep to view the smallest mitral orifice area, and then tracing of that area will follow. If we have the luxury of 3D probe, we can use simultaneous biplane. So we align the cursor here at the mitral leaflet tip, and then we obtain a short axis from this long axis view. And then when we do that, we will make sure that we are really aligned at the mitral leaflet tip, and then we can do the planimetry with high accuracy. And when 2D image quality is good, 3D imaging is available. The 3D planimetry is the most accurate and superior method, particularly when viewing the mitral valve from the LV perspective. Mitral valve area by planimetry has the advantage of not being affected by load condition and beat-to-beat variability that we see in pressure half time. Particularly those people with mitral stenosis, they might have arrhythmia and atrial fibrillation and a lot of changes in the gradient from beat to beat and pressure half time. But if we do a 3D planimetry or planimetry, usually it is not affected by the loading condition, and it is a really accurate method to do it. Now we have also the pressure half time for mitral valve area, which is a well-validated method that comes with its limitation that we already spoken about. As mitral stenosis get more severe, the pressure decline and the LV filling takes a longer time. So pressure half time becomes prolonged. And by utilizing an equation, we can calculate the mitral valve area. So mitral valve area, MVA, will equal to 220 divided by pressure half time. And then we will get the area by square centimeter. Having mentioned that, we need to know that sometimes there is a bimodal. Let me just delete that. There is a bimodal flow or spectral Doppler. That means that there is at the beginning there is a tip peak, and then the mitral inflow will decelerate quickly, and then we will have the plateau all the way. So what we need to do to get an accurate pressure half time is to ignore that tip and just take it from after the tip. We measure the pressure half time, and that will be the most accurate in measurement of pressure half time and corresponds with the valve area. However, if we took measurement from the tip all the way down here, that will give us inaccurate estimation of the valve area. The continuity equation for mitral valve area calculation is well validated, and we can use it. You can go back to the hemodynamic lecture to know more about continuity equation. However, in the presence of significant aortic regurgitation, then we cannot use the LVOT stroke volume. In case of atrial fibrillation with significant beat-to-beat variation, again, continuity equation will have some limitation. PISA method also can be used. However, it is rarely used in mitral valve calculation, but still applicable. Okay, because the mitral valve leaflet, they affect the hemisphere area, unlike regurgitation. So in mitral stenosis, we need an angle correction. So let me show you. If this is the mitral leaflets and they are like tethered to each other, in mitral regurgitation, we will have the hemisphere somewhere here. However, in mitral stenosis, the hemisphere will be down here. And that will or the mitral leaflets will create an angle that we should correct for. The angle will be somewhere here. This is one angle. This is, as you can see it here. And then we measure the angle. For example, in this example, the angle here is theta, and then we have to correct for that angle. Unfortunately, a lot of post-processing software in echocardiography doesn't measure the angle. The equation will be mitral valve area is 2 times pi times r square, which is the area of the hemisphere. R is the radius from the vena contracta to the flow conversion zone, or the change of color, the Nyquist limit. Then we time it by the velocity 1, which is the velocity here of that area. We will know it from the Nyquist limit. And then we divide it by V2, which is, we measure it by continuous wave Doppler. And then we have to correct for the angle by multiplying the result by theta divided by 180. By doing this, we will correct for the angle. However, as I just mentioned, the software is usually or rarely available to measure the angle. Now we have other parameters that also can help us in supporting our grading. The mean gradient, which is, as mentioned, is heart rate dependent. The way to do it, we have to optimize the angle of the ultrasound beam to be as parallel as possible to the direction of the flow. And the way to do that, if we apply a color flow Doppler, we should see the direction of the flow and then try to align our CW cursor. Since LV filling of the mitral stenosis occurs during diastole, unlike normal mitral valve, when you have only an early diastole flow and then you will have the atrial kick, but in mitral stenosis you will have early diastole that will continue all over the diastole until systole starts. So this is why it's heart rate dependent, and if we have a higher heart rate, as just explained, the volume in the LA will increase and causing increase of the pressure. So this is one of the drawback of the gradient for assessment of mitral valve stenosis. Another thing is, sometimes or many times in rheumatic mitral stenosis or rheumatic heart disease where we have mitral stenosis, there will be a coexisting mitral regurgitation. And if there is a significant MR, i.e. moderate or more, that will also cause increase in the gradient. So again, the gradient will not represent the mitral stenosis alone, but it will also represent mitral regurgitation. In atrial fibrillation, again, we will have a beat to beat variation. So usually we have to average 5 to 8 consecutive beats. Mean gradient of less than 5 is unlikely to be found in severe mitral stenosis. Mean gradient does not have any role, again, in the decision for intervention, which is based primarily on the mitral valve area and symptoms. So except if we have a mitral valve area which is more than 1.5 square centimeter, but patient is still symptomatic, then that time we can stress the patient and then we go ahead and see the gradient and it will increase up to what level. And then that can help us in the decision for the intervention. Again, in significant mitral stenosis, we also expect the left atrium to be enlarged. This is an extreme example, but a normal left atrium really rule out significant mitral stenosis or normal left atrial size. So as you can see here, the left atrium is really huge. Thank you for watching, and I will stop here. Next lecture will be the mitral valve part 2, where I'll speak about the mitral regurgitation.